Hello, everybody. Happy Webinar Wednesday. I'm Amy Hajari Case, and you are in the PFF Disease Education Webinar Series. So we are very privileged today to have Janet Talbert with us. Next slide, if you wouldn't mind. Janet is a genetic counselor. Her focus for a long time has been in pulmonary diseases. And I can't think of anybody better to talk with us about the topic of pulmonary fibrosis, genes, and families, and the role of genetic counseling in those disease areas. So we have a really packed session for today. I want to give you a couple of reminders, and then we're going to try some polls before we get started. Before we launch into the content, we have some slides that you can download from the right side of your control panel. If you look down to the handout section, these slides are there. You can download them in PDF format and take a look at them later. If you have questions during the session, there is a questions bar on the control panel. So just type your questions in there, and we will try to get to as many of them as we can. We'll have a couple of poll questions, some interaction, and you'll be able to click your responses. We'll see what people are thinking. And then at the end of our session, please stick around for just a couple of minutes and give us your feedback. There will be a survey that comes up when we're finished. There will not be one emailed later. So if you could give us your feedback so we can always make our webinar series better, we would love to hear from you. So I'm going to get us started just quickly and take everybody's temperature here with our first couple of poll questions. Have you encountered a genetic counselor before? Give everybody a little time here. So we're going to hear a little bit about what is a genetic counselor, besides we know Janet is one. So we'll hear from everybody about that. So looks like we have about, give everyone a few more seconds here. Got a good quorum, and we have 70 plus, almost 80% of our folks here have heard of a genetic or have encountered a genetic counselor before. That's fantastic. And then we have one more question here before we get started. What percent of IPF runs in families? I don't know if you guys know this, but if you're taking a test and you don't know the answer, C is always a good option. Everybody's responding. We're getting some numbers here. And all right. So we have, let's see, the majority of people said 20%. So we'll find out if that's right. So thank you guys for participating early. We know everybody's awake and paying attention. Janet, thank you for being here, and I will kick it over to you.
Okay, great. So, okay, well, hello, everybody. I'm sure that I've spoken to many of you before, and some of you are just now being introduced to me, but I have been working with pulmonary fibrosis since 2003, so that's 18 years, and I was and I am among some of the best researchers in the field, and really I stand on their shoulders and what I've learned from them as far as the disease. And then I've been able to help contribute with the genetics so far. But I started out as a study coordinator in the familial pulmonary fibrosis study. I was already looking at becoming a genetic counselor at the time, and that really was like the nail in the coffin that drove it home for me. So I decided to go get my master's, and right about the time I was graduating, we actually had some breakthroughs and discoveries of genetics and pulmonary fibrosis. So that led us to creating a telephone line that patients or family members, even clinicians, doctors, nurses could call across the country and get more information about the genes that have been discovered so far. And then I did some other genetic projects at National Jewish, working in our laboratory. And by 2014, I just kind of wanted to step away and a little bit. I never stepped fully away from pulmonary fibrosis. I always did my telephone line and consulted with National Jewish, but I wanted to learn more about what other fields have learned about later onset disorders that run in families like cancer, or neurology. So I was an instructor at the University of Colorado. Both of those were in Denver, National Jewish Health and University of Colorado. I worked for a year there in cancer genetics, inherited cancer genetics. And then I left from there and worked at a company called Informed DNA that provides genetic counseling and genetic testing services nationwide. And I really got to explore other areas as well, as in oncology, retinal disease, neurology. And I wanted to start my own pulmonary fibrosis program, um, because they were starting to even work with clinical trials, enrolling people in clinical trials that were genetic, and counseling them on the front end, the back end, and a really exciting time. And then of course COVID hit, and all the pulmonary world was wrapped up in that, as they still are, unfortunately. But in the meantime, I was recruited to Vanderbilt, back in my hometown of Nashville, Tennessee. I was born right down the street. So I ended up back here for a special project. But the lucky thing is there's a huge, well-known group here at Vanderbilt studying families and genes, and there's some of the cutting edge researchers here. So I'm able to make that my clinical area. So I'm really lucky that I kind of have my home disease area to work in. A couple of disclosures: I am on the medical advisory board for the Pulmonary Fibrosis Foundation, as well as a healthcare ambassador. It's probably where some of you have seen me before. And as always, I am not a physician. This is not take this and run with it. Please, it's really informational and educational purposes only. Um, Always ask your doctor for any professional medical advice, and consult with your doctor as far as any kind of medical treatments for your condition. So this is really just information that you can go back and ask your doctor about. So I'm glad to see that most of you have heard of a genetic counselor. I do get that a lot at parties. Sometimes, what do you do? So, we're not doctors, even though sometimes I secretly do like being called the doctor. Thank you, Dr. Amy, for reminding me I stayed at a Holiday Inn, or I play one on TV. But I just have a master's degree, but it's in medical genetics and special training in psychosocial counseling. So I'm really here to support the patients and the physicians, because physicians don't have a lot of heavy training in medical genetics, and they can't keep up with the field because it's evolving so fast. We are board certified, just like medical genetic doctors are. So we do take a 4-hour test, and we have to maintain our continuing education to maintain that board certification. But overall, genetic counselors have always been part of the healthcare team. Traditionally, they've worked in clinics back in the beginning of our field, like maybe the 70s, because you remember DNA was discovered in the 50s. So it's still fairly a new field. But genetic counseling was born out of the prenatal and pediatric realm. Um, People having genetic conditions running in families, like cystic fibrosis or alpha-1 antitrypsin or sickle cell anemia, trying to mitigate those, or diagnose them in the pediatric setting or newborn screening. But as we've learned more about the genome, and genetics has really running across all disciplines of medicine, pulmonary, cardiology, gastroenterology. And that's why, one of the reasons I was hired here is to help those non-genetic professionals understand all the genetic testing results that come out and how complex they are. And genetic counselors can work in laboratories, writing reports, interpreting results, research, what I was kind of doing, gene discovery, grant writing, and even public policy and lawmaking. But at the end of the day, we're educating. which is what I'm doing today. And just to put it in perspective, there's about 5,000 trained genetic counselors in the US, but there's over 6,000 genetic disorders. So there's definitely a gap. And if you have any children or grandchildren looking for a career path and they like science, this is the future of medicine. So it's an exciting time to be in this field. A typical genetic counseling evaluation involves looking at the diagnosis a patient has, looking at the family structure to see if there's any patterns, the same disease or maybe diseases that go with it, and help determine what genetic tests might be necessary, who might need testing, discuss any risk that go along with it or benefits for genetic testing, help facilitate those orders and interpret the results. And sometimes there are things we can do with genetic test results. We can maybe discuss how it's causing the disease and what we know about it and what we know about the inheritance pattern, who else is at risk, but also, are there any treatments or medical interventions we can do? For instance, in cancer, we can do colonoscopies at a younger age if there's a higher risk for colon cancer, or breast cancer, we can do additional screening or even prophylactic surgeries. And you may know people that have gone through those. And because genetics does, there is a psychosocial impact of knowing about a genetic condition or being able to discuss it or find others. Usually it's in rare diseases too, so we like to provide support and resources. And so why do we care about this in pulmonary fibrosis? Well, for the most part, most pulmonary fibrosis is not what we think is strongly genetic, but the idiopathic forms, definitely we do see running in families. And so maybe we can define that causative factor and help maybe get to diagnosis quicker. I know in my years of working in this, a lot of people went through misdiagnosed for a long time until sometimes it was too late. So it could also improve our understanding of how the gene is causing disease, and maybe that makes it a target for potential treatment options. And as far as where we are for pulmonary fibrosis, we have found genes. We think we understand how they're causing disease. We can test individuals if it's appropriate to do so, and we're able to identify others possibly in a family, especially if we have a mutation or a variant. But our knowledge stops about right there. But I think we're on the horizon of getting where we can move further into this list for using it clinically for patients, possibly treatment options. I'm going to be talking about one today. But at the end of the day, I think we're moving in the right direction. We're kind of behind the cancer field and other fields, but we're not that far behind. So I like to show this slide just to kind of point out, let me see if I can get my mouse here. Interstitial lung disease, over 100 disorders fall under this. Many of those we know what's causing the scarring. So a lot of the genetic work has been in the idiopathic interstitial pneumonias. So most of what I'm going to be talking today is in the idiopathic form. And we know that, these can transmit in families. And some of the genes we've discovered do have some crossover with other known causes like rheumatoid arthritis or hypersensitivity pneumonitis. So there may still be an underlying connection at the end of the day. So this is a pedigree. And we use this a lot in genetics all the time, actually. It's basically a family tree. Squares are males, circles are females. Usually we color in the person with the diagnosis and put an arrow there. In this case, this family, we only see one person affected with the diagnosis. In this case, it's IPF. And so we'd really call that sporadic or random. And this is the majority of what we see when we see a patient in clinic. But if you contrast that with some of the familial pulmonary fibrosis pedigrees, you can really start to see that there are patterns, that it's not always in just men or just women, or it's in multiple generations, or maybe it's in one generation. And so this is pedigree, just kind of gives you a quick visual on who's affected in the family, how it's transmitting in the family. And I want to point out, sometimes people will say, well, it skipped a generation. And I just want to tell you that genes don't skip generations, the disease will. So a gene either gets passed down or it doesn't, or a gene variant gets passed down or it doesn't. Whether it manifests or not is what we call skipping a generation, and in fancy terms, in genetic terms, that's called reduced penetrance. So if you think about something being fully penetrant, means the disease is showing, but if it's reduced, maybe it's 80% or 40% or 10%, then it may get passed down. And here's an example right here where it looks like it skipped a generation, but really that person just didn't manifest the disease. Okay, so that's something that is matching up with the genes that we've discovered for pulmonary fibrosis, and even in hereditary cancer, we see this as well. So for the people who answered 20%, you were right, up to 20% of families or patients do report a positive family history. And so you gotta have a pie graph, you gotta have a graph in a presentation. So this is my pie graph. The majority, you can see right away, don't have a family history. And out of that 20% that we do see migrating in families, we can identify a gene mutation about 5% of the time. So if I put up a breast cancer slide, it's going to look just like this, or cardiomyopathy slide, it's going to look a lot like this. So we're seeing this pattern in different areas of medicine. And because some fields are ahead of us, that way we can kind of follow in their footsteps and kind of use what they've already learned. But this number comes from, if you take about 25% of families, that's what we're finding will be tested and have an identifiable gene mutation. This slide, very busy, and I don't apologize for it because I think it shows how complicated the genetics of pulmonary fibrosis is. It was already a complicated diagnosis, and the genetics are proving even more so. Now, all of these letters are acronyms for genes. So anytime you see these letters, they're genes. The little circles just represent like how often it's reported. So we know right away that pulmonary fibrosis is not a single gene to be tested for. So that's one take home I want you to have today. There is no, I want to get tested for the pulmonary fibrosis gene. You can see that there's more than one. The rare variants are the ones that typically we think of that transmit in families and have a stronger penetrance or a larger effect size, but they're very rare. So it is rare, and that fits with that 5% on my pie chart right above it. Not everybody walking around has a rare variant that's highly penetrant, and that's what you want in any kind of disease, right? You don't want everyone having it. However, if you move along the x-axis here, we start to see more common genes with variants in them that are in the general population, along with people with pulmonary fibrosis. Many of you may have read about MUC5B. I was part of that discovery as part of our studies at National Jewish. It seems to have kind of a significant amount, a significant proportion of being associated with the development of pulmonary fibrosis, but it's also pretty common in the general population too. Not everybody who carries that variant gets pulmonary fibrosis. And so I'll talk a bit about the differences between common variants and rare variants, and I'll come back to this slide for illustration. So because we have all these multiple genes, you need to know which gene to test for your family or for your background. Cost, the good news is the cost is coming down tremendously than it was 10 years ago. But what are we going to do with the information? How is it going to change your clinical care if you have the diagnosis? Or what's it going to do for family members who may be at risk and carry that same mutation? How's it going to impact insurability? And how are we going to keep this confidential? And what are we going to do? How can I link up with someone else who maybe has the same condition and even same gene mutation? This is why genetic counseling is so important about this information, because there's so much baggage that comes with it. And the psychosocial impact, a lot of people, most people I've never met with a genetic counselor had genetic testing. So sometimes that is just anxiety producing. Could this be genetic? What am I going to find out? You know, I'm sure a lot of you have even found out, even through companies like 23andMe, that people are finding out their parent isn't their real parent, or maybe they have family members they didn't know about. So sometimes this can come with a lot of baggage when you get genetic testing. We want it to be personal, but you share your genes with your family. So as far as pulmonary fibrosis, you know, what we're talking about mainly is risk. Are you going to develop it? Are you going to pass it down? Sometimes it's a risk just to learn that you carry that mutation, if you do carry that mutation in the family, if there is one in the family. And I think the familial pulmonary fibrosis population is particularly, um, special because, you know, over the years of working in pulmonary fibrosis, and even myself, I had never heard of pulmonary fibrosis until I started working in it. So most people had never heard of it when they get diagnosed. But when you have it in a family, you've seen what it can do. You can see that you've seen other people suffer, then you're diagnosed. I think now we have a little, we definitely have more tools in our toolboxes than we did before the drugs came out. But before, it was really scary to get that diagnosis, especially if you'd seen it before in your family. And in genetic counseling, we always talk about survivor's guilt. And this is where there could be a gene mutation in a family. And let's say there's 6 siblings and they all go get tested to see if they carry it. And 5 of them have it and 1 person doesn't. So you would think it's good news to say, hey, I don't carry this, yay. But a lot of times people have guilt with that because they're not in the same boat with their siblings who do carry it. And so they feel left out. So there's a little bit of survivor's guilt in there. But one thing that keeps me in this patient population, and it's so admirable, is that so many of these families I've worked with over the years, they just want to help the next generation or help somebody. They feel like they're in a special place to help someone else not go through the suffering or the disease process, or possibly they just want to help and contribute to research. So thank you all if you've contributed to research. The main people I talk with, or even clinicians, are about families who have 2 or more, and that's what we call familial pulmonary fibrosis, 2 or more cases in a family. And of course, if they don't have the diagnosis, they're worried about their risk to get it. If they do, they worry about their children. And with reduced penetrance, there's still a small risk to children, even of people who don't have the diagnosis. I've heard families decide not to have children just because it runs in the family unless they can find a gene mutation. So these are the patients I usually counsel the most with a family history and talk about genetic testing options and definitely research. But on occasion, we do get patients with no family history where we do still suspect that there could be a genetic mutation at play there. Maybe there's some other personal or family history, or just maybe they're concerned because it is a rare disease and they've never heard of it. And of course, the common variants are represented in sporadic cases, sometimes at a higher rate than the familial cases. So down the road, they may become candidates for genetic testing, perhaps for research or even clinical trials or clinical treatment. So, recognizing that this is about halfway through my presentation, I just want to kind of revisit genetics and some terminology so I can move forward. Basically, we all start out as one cell. We get half our genes from our parents, a half from each parent, and to make us whole. And I'm not going to go over the birds and the bees with you guys. I expect you already know that. And but the physical structures that the sperm and egg carry that carry our genes are what we call chromosomes. And chromosomes, we have 46 as humans. We get 23 from mom, 23 from dad. And chromosomes are really just tightly wound coils of DNA. And our DNA is made up of 4 letters, a code. So it's perfect for doing genetic testing and putting it through a computer. And so we have a whole field called bioinformatics that can code for genes and gene mutations and gene mistakes or variants. And our DNA is very tolerable of mistakes and variation. That's why we all don't look like each other. And only identical twins are identical. And even they have changes over their lifetime. But mutations, I'm going to call them variants from now on, because variants can be good, variants can be bad, variants can be inconclusive. So variation could be, maybe this C becomes a T, and that sets everything off. Our genes are very smart, and they are able to sometimes kill off gene mutations. Cancer is a good example where they can't, and that gene mutation goes rogue. So I know all of you have probably heard of Down syndrome. Down syndrome is a complete extra copy of a whole chromosome. So you have 3 chromosomes instead of 2. So you have 3 copies of every gene. So there's lots of ways that DNA can, have mutations or differences that can cause human disease. But where we've focused the main part on is sequencing, just finding like even 1 letter off for pulmonary fibrosis. But we can even have whole parts of the gene deleted or duplicated, and it just depends on whether it's tolerable by the gene. And I tend to think of our genes like books in a library. The library is your genome, and you got half your books from your mother, half your books from your father. You have 2 copies of every book. And when we do genetic testing, usually we're taking a certain book down or maybe a couple of books down and reading through those books to look for typos. And just as in the English language, there's typos that are annoying, but they don't really cause much trouble, like 2, 2, and 2, there, and there. But we're looking for the typos that can really cause damage, keep you from reading that book, keep that book from being readable in general. But sometimes, because we haven't tested every human that's ever lived, will live, or is living, we come across a typo that we've never seen before. And it doesn't always mean that it's bad. And there are rules when to say it's harmful or positive and it's hurting the gene and it's causing disease. And there are rules when to say, nope, this is pretty normal. It's a 2, 2, and 2 situation. But because we haven't extensively tested every person on this planet, you could have a variation somewhere that just makes you who you are. It doesn't mean that that's causative of disease. And unfortunately, we come across that a lot in our genetic test results. It's inconclusive, and a lot of people don't know how to interpret that. So just be careful, and that's why a genetic counselor can help you interpret those test results. So back to genetic variation. So rare variants or mutations in the past have been called less than 1% of the population. It's rare because it's rare. And usually they're the ones that go in families in recessive or dominant disorders, have that reduced penetrance. We think about those with genetic syndromes like cystic fibrosis, sickle cell anemia, Huntington's disease, and even hereditary breast cancer. Some of you may have heard of the BRCA gene. These genes have that stronger effect, and the variants can be anywhere in that book or gene. But when you contrast that with the common variants, they're in greater than 1% of the population, but they also can be inherited, and they're more associated with disease risk. So they might say, oh, this actually protects you from heart disease or diabetes or pulmonary fibrosis, or it increases your risk. And companies like 23andMe have harnessed that power, and they even, I don't recommend getting pulmonary fibrosis testing through 23andMe because they're usually looking at these common variants. And we know that a certain percent of pulmonary fibrosis patients are going to have those common variants, but we also know that people without pulmonary fibrosis are going to have those variants. So it's not very predictive right now. It just tells you maybe something you already know, that you have a risk for it. But these typically have a smaller effect in the risk for disease. They do become therapeutic targets, though, because they're the same variant in every person that carries it. So in the rare variants, we're looking through the whole book just to see if something is bad in there. But common variants, we're going right to that typo on page whatever, paragraph whatever, word whatever. And it's either there or it isn't. And so that becomes a target for a possible therapy in the future. So again, we're talking about rare variants versus common variants. So let me spend a little time on the rare variants. And I just want to point out that all the genes, these are the genes in black, are what we call telomere genes. And the ones in red are what we call surfactant genes. And those are really the two camps for the rare variants that tend to migrate in families and are more associated with a familial or inherited form of pulmonary fibrosis. So what are telomeres? Telomeres are the ends of our chromosomes, kind of like they protect our chromosomes from fraying during cell division. So what happens is every time your cells divide, your DNA is exposed to cellular processes and they just want to eat up and clean up everything. And so these telomeres act as like little shoelace covers, aglets, if you will, at the ends of your chromosomes to protect that from happening, because if your DNA gets eaten up, your cells die. And then what's interesting about telomeres is there's multiple genes that make this process happen. And many of these genes have, if they have mutations in them, they cause the telomere to shorten prematurely. And that might, and so a lot of the telomere diseases are diseases of aging or premature aging. And we think pulmonary fibrosis falls into that category. And that's why we've been able to find these gene mutations. So you can measure telomere length in the blood. It takes a special test and special testing, but it's really kind of a screen. So typically what we would expect to see is that the older you are, the shorter your telomeres are. Telomeres are supposed to shorten with age. It's an aging process. So I have shorter telomeres than a baby, but my parents have shorter telomeres than me. And it can be highly variable. The biggest indicator is age, but it can vary by family, it can vary by individual, and even males and females. And then it can vary by tissue type. So say cells with high turnover, like in the lung, the liver, the bone marrow, those are turning over and replacing each other so quickly that that process is sped up, especially if there's a mutation there. But say something like the brain or the spinal cord, that doesn't really regenerate. So those telomeres are going to be longer. So it was in 2007 when the first report between Johns Hopkins and the group here at Vanderbilt reported two genes, TERT and TERK, were in a significant proportion of familial pulmonary fibrosis, about 15%. And that's, pretty on par with, say, hereditary breast cancer, which is 10 to 15% for certain genes. And that was about the time I was graduating from my program. So the two just kind of came together and we took advantage of that and made that telephone line. So, like I said, telomere length is supposed to get shorter as you age. And if you remember your percentiles, everybody wants to be on this 50th percentile. You don't want to be too big, you don't want to be too little, you want to be just right, right? So when I'm, let's say I'm 20, right? I'm 20 years old. So my telomere length should be about right here. But when I'm 47, it should be about right here. So that is normal. But what we see when people have these gene mutations, that they fall sometimes well below the 50th percentile. So you can actually measure telomere length and see where you are on this spectrum. Now, I will say that most people with interstitial lung disease are usually at or below the 50th percentile because pulmonary fibrosis is a disease of aging. But when you start getting below the 10th percentile here and at the first, I think that enriches for a gene mutation to be found in one of these genes. So some things I look at when I'm working with a family, again, the bulk, about, I would say about what, eight genes now we've discovered in the telomerase pathway. Sometimes just having 2 family members with pulmonary fibrosis is enough to offer genetic testing. And I want to stop here before I forget. It is best to test someone with the diagnosis of pulmonary fibrosis in a family rather than an unaffected family member. And this is because the way these genes are passed down, it's 50-50 to the next generation. I always say if you're looking for a needle in a haystack, start in the right haystack. You want to start and see if there's a 20 to 30% pickup rate for a telomerase mutation. You want to start with the person in the family with the diagnosis. And if they don't have any mutations in those genes, there is no point in testing anyone else because we still don't know for 70% of familial what is the gene mutation that's causing it, or even the gene. But I like to look for other indicators, and the more of these that we see, the more it enriches for a gene mutation. So we see liver cirrhosis of unknown cause, we see bone marrow failures in these families, and it doesn't have to all be in the same patient. It could be spread across the family. One could have leukemia and one could have pulmonary fibrosis and one could have liver disease, or it could be all in the same. My least favorite category is premature grain because other things cause premature grain, other genes cause premature grain. So just the fact that someone went gray early isn't a strong indicator, but a lot of people like to navigate to that because it's easy to see. But don't panic if you prematurely grade. It does not mean you have a gene mutation. It just means that if it's present along with all of these other factors, it just enriches. For the surfactant genes, we usually see a lower pickup rate, even in the families. We usually see younger age of onset, or pulmonary fibrosis across the age span, like a grandfather with a late onset, but then a child with pulmonary fibrosis. And then this is a limited list of very rare genetic syndromes that would have been caught early on that have other syndromic features, like Hermansky-Pudlak has albinism. So we don't typically see those in our clinic for late onset because they've already been caught by other medical providers. So a little bit about the common variants, again, greater than 1% of the population, associated with risk, therapeutic targets. Again, the section here, and if you notice, TERT keeps coming up, but TERT is a telomerase gene, so that might, but this is one particular variant that keeps coming up, MUC5B. Going on 2 years ago, the Pulmonary Fibrosis Foundation announced about the Precisions trial. And what they're trying to do in this trial is see if the drug NAC is more effective in people with a certain common variant, or if it's harmful, harmless, doesn't do anything, does something, so that you can take that drug and say, no, you really don't need it because you have this variant, or maybe you will need it. It works better for you if you do have it. So that's an example of a clinical trial utilizing genetics to try to see if it can make a therapy for a patient. And we see this in other areas, cancer. If you have certain variants, they're going to use this chemotherapy or this treatment. So there are risks and benefits of genetic testing. I think learning genetic status falls in both categories. Some people don't want to know they carry a mutation that's going to put them at risk, but some people do. They feel like it's empowering. The cost is coming down, but some people can't afford genetic testing. So therefore, they don't have that access. but some people want to know for even reproductive planning, down generations, if there's any way to prevent the manifestation of the disease, if they want to participate in clinical trials, or if they just want peace of mind, like, hey, this mutation is in my family, I do not carry it, I can, if I don't have survivor's guilt, I can feel pretty good about my chances. I do get a lot of questions about genetic discrimination, and it really kind of depends on if you're affected or unaffected. Genetic discrimination historically was fear-based. It really wasn't occurring, but a federal law signed in 2008 really blanketed all other state laws. So your state may have their own laws, but this GINA, I'm not a lawyer, I don't want to know every state law, so I just stick with GINA. It blankets all the other states. It's relieved a lot of fears about genetic discrimination because people wouldn't even participate in research sometimes. So what does it do? So for health insurance, basically health insurance cannot force you to take a genetic test. They can't require you give them results. They can't set premiums or coverage or rates or deny you eligibility. This is for health insurance. It can't be used as a pre-existing condition. Family history alone used to be something that, possibly health or even life insurance could use against you. But in this case, they can't use family history or a genetic test result against you for access to health insurance. Employment, you can't be hired or fired, denied promotion if you have a genetic mutation or variant. But what it doesn't do, it doesn't mean that just because you have a genetic mutation or variant that your insurance has to pay for all the treatments and everything. It does benefit, like in cancer, it does benefit insurers to pay for genetic testing and some of the therapies because those don't cost as much as cancer treatment. But it doesn't mean that they have to. For the military, the federal employees, and the Indian Health Service, they really have their own law that was already in place before GINA came along. So GINA doesn't apply to them, but they have their own coverage. So don't think that they're left out. But a really important take home I wanted to say is that this law does not protect the manifestation of a disease. So if you already have, say, pulmonary fibrosis, and we know it's from a gene mutation, if we didn't have the Affordable Care Act and they wanted to use it as a pre-existing condition, a health insurer could do that. But it doesn't protect for the disease, but the genetic test result. And I just realized I didn't have on here a big one. GINA doesn't cover life insurance or long-term disability. So life insurers could use a genetic test result against you. So a lot of people will go out, get their life insurance set up before they do genetic testing. Okay, so here is some of the resources. Of course, the Pulmonary Fibrosis Foundation. If you don't have the opportunity for genetic testing or don't think it's right for you or it's not really appropriate based on your family history, there's always DNA banking. DNA banking is a way to keep your DNA safe for other family members to test way into the future. And of course, I have some GINA information there too. Amy, I think you wanted to join in right now.
I think I'm back.
Okay.
Oh, wait, camera. There we go. That was really wonderful. So much information. And we have actually a lot of questions.
Okay.
I actually wanted to, we have about 10 minutes left. I wanted to try and get to as many of those as we can. This is a really interesting topic with a lot of, like I said, a lot of questions that people have. So one question we received was about any connection between IPF or other types of interstitial lung disease and COPD in families. There's families out there, maybe some people have family members with COPD or emphysema and others with lung fibrosis?
Not that we know of as far as from a genetic standpoint. I think, you know, what I've heard some rumblings of is in COPD, they also have shorter telomeres. I don't think that those genes, though, have been highly representative in COPD. And, you know, uh, Amy, you can speak to, as a doctor, the difference between uh, pulmonary fibrosis being a restrictive lung disease and COPD being an obstructive. It could just be coincidence. And we do even see people, I believe, with, you know, both fibrosis and emphysema, if I'm recalling that correctly, right, Amy?
That's absolutely true. We do see some patients with an overlap syndrome, and there are some similar risk factors for particularly IPF and COPD, smoking being one of the biggest of those. But I'm with you. I don't know of any particular genetic links between those types of disease states, and they are a bit different as it pertains to the physiology of those problems.
And it could be in an environmental, because I didn't, of course, there's so much information I wanted to share today that I couldn't put it all in this, but, you know, it could be that there's a underlying genetic predisposition, and then it depends on the environmental trigger too, whether you get one thing or the other. We know that occurs in autoimmune disease because some families have autoimmune disease, and one would have rheumatoid arthritis and another person might have psoriatic arthritis, but they're actually tied together from a genetic standpoint.
Absolutely. That's a really great point in the disease manifestation being different. So some of these questions were answered. I'm going through. There's an interesting question here about you mentioned a future state of potential treatment options that might be different based on genetics. We did have a question about potentially in the future, if there is a family with a genetic mutation that is linked to their pulmonary fibrosis, would there be a treatment like a CRISPR type therapy that would be able to alter that gene and solve that component?
I hope I see that. I mean, I hope I see it in 5 years. Of course, that is the goal. That's the long-term goal. They are already doing FDA-approved clinical trials with CRISPR in a couple of different disease areas, and it's showing a lot of promise. And all you need is to have that happen for one area before they start moving it over to other areas. So that is the ultimate goal, is to be able to go in and fix that gene and have it work correctly so that it doesn't cause disease down the line.
That's very cool.
But we're not there yet, but
No,
we're close.
that's right. The more we learn. So another really good question, as we're learning more and have better tools, do you think that we're going to see a higher percentage of patients with pulmonary fibrosis truly be familial in the future? You think those numbers will go up as we understand more and are looking harder?
I think it'll go up a little bit because it already has. So I think when, you know, you look back at the literature, they thought only about 3% of families, you know, had familial, and now it's up to 20%. And now that we're finding more and more genes, and especially even with the common variants, it might go up a little more, but it's kind of staying on par with other diseases that have more inherited forms versus sporadic forms. I wonder if pulmonary fibrosis is going to break away and not be a rare disease anymore. And I know with COVID, Amy, you could speak to that. We might even have a lot of false positives for familial pulmonary fibrosis in the near future. I've wondered about that, and we're already kind of seeing that here at Vanderbilt.
I do wonder about similar risk factors, though, and maybe that's a trigger to develop that in the future in somebody who might have a genetic or other predisposition to an aberrant response to a lung injury. So it will be important, I think, for the medical and scientific community to continue to understand that as we move forward, given the sheer number of people in our country and worldwide that have been affected by the pandemic, and certainly those in families of patients that have pulmonary fibrosis. Go ahead.
Oh, well, what we want to see is we want to explain the 70% of familial families where we don't have a gene or a mutation, what's going on in them. So we really want to fill that gap so that we can really start driving more therapies and causation and being able to warn others or identify people early.
Absolutely. Okay. Another question. This is actually really an interesting one. I thought about as well. If in a particular case of pulmonary fibrosis, there is an identified, or in a family, an identified gene mutation that is the cause of that, does that contradict the notion that this is idiopathic pulmonary fibrosis? Is questioning the terminology, I think.
Right, and that one of the first slides I had, define the causative factors, take that idiopathic out of the picture. So yeah, if there's a causative mutation, it's confirmed to be pathogenic or disease causing. We really wouldn't call it idiopathic. We would call it familial or inherited. I don't think our field has gotten that far in calling it inherited, like hereditary breast cancer, but we would call it hereditary pulmonary fibrosis. We would know the cause then, and it wouldn't really be idiopathic anymore.
I completely agree. I think the term familial is a little easier to understand, I think, although that does apply to people that don't, as you said, that 70% that don't have an identifiable mutation. But I think if you want to go with a mouthful of familial with an identified gene mutation versus those that don't yet have that, I think that's a good point. That does lead to a couple of other questions. I'll go ahead and give you both, and I'd be happy to comment as well, about the prognosis for familial pulmonary fibrosis with I'm guessing this is with an identified genetic mutation. Is that the same as more sporadic type of IPF? And then same question for antifibrotic therapies.
Okay, so two-part question. So I have no firm data that familial patients do worse than sporadic patients. I think, there's some question, especially with the telomeres and the telomerase mutation, if they don't fare as well after lung transplant. And that's a new thing that the field is looking into to maybe try to prevent that from happening going in. Genetic testing might actually become a requirement before lung transplant so that they can treat them better on the back end. I feel like a long time ago when the clinical trials were going on, there was some question if the familial fared worse in those studies, but I don't think the data ever showed that. And Amy, you might want to help me there with that one. I don't see.
I agree. I don't think that's true. What I always think of is that the presentation seems to happen sometimes earlier in familial cases, not necessarily that disease progression is either more uniformly more or less aggressive,
Right.
but that they oftentimes do present at a younger age.
And just to launch off of that, I mentioned it's better to test a person in the family first for the that has the diagnosis. And then if you find a gene mutation, it's a 50% risk to children or siblings to have that mutation just by default. But with that reduced penetrance, it doesn't mean that a mutation carrier is going to get pulmonary fibrosis, but it could lead to them being screened more frequently to see if the disease ever starts to manifest. And if it does, then possibly the treatments available to slow progression now could be used in those patients.
Yeah, and used earlier, which, you
Yeah.
know, if we're talking about preservation of lung function,
Mm-hmm.
would you know, prolong that lung function
And
from
on,
there.
can I add
But
one more thing to that? And what I tell people is you don't really have to have a genetic test to say, go into your doctor and say, this is in my family and I'd like some baseline screening. Um, even with a gene mutation that's known, and if you know you carry it, you're still going to go get baseline screening. So baseline screening is available if you have a strong family history of pulmonary fibrosis. Unfortunately, there's no guidelines right now, but hopefully with studies like at Vanderbilt doing early IPF studies, we may come out with some guidelines in the future.
absolutely. And we have just 1 minute left
Oh,
here. Yeah, we've got some
ah,
great questions, and we will try, for those that we didn't get to their questions, we will definitely try to follow up with you to answer as many of those as we can. There's just so much interest and engagement on this topic. So I thank you, everybody, for listening. I do want to mention two things before we wrap up. That is, next month is, there's some familial, this is all in the
yeah.
downloadable handout, so don't
Okay,
think you
good,
have to
good.
screenshot or anything like that. But I want to mention next week is September 1st. It is starting Pulmonary Fibrosis Awareness Month. So if we have a ton of activity going on, there's several webinars during the month. Lots of facts coming out on social media and plenty of ways to get involved. So if you want to take a look at the PFF website for ways to get involved in that. And also, I want to remind everyone that the biannual PFF Summit is coming up in November, and registration for that is open now. It is going to be virtual, no travel, so you can just log in from the comfort of your home, camera on or off, and get logged into some of the best PF education out there, and time to interact with experts in the field, from academics, from clinical realm, from industry, patients, caregivers. Lots of great information and sessions happening there. So you can go to the website and register right now for the summit. So we hope to see you all there. And I'm just going to wrap up by saying, Janet, thank you so much for joining us today. This has been a really great session. I always learn so much when I get to listen to you, and I know our community really benefits every time they get to
Yeah.
see you as well. So thanks so much.
Thank you, and I appreciate everyone tuning in today. And if you have any feedback for me, feel free to share it. I'm always trying to make things better. So,
Great. Thanks, everybody. Stay safe out there, please, and we will see you at our next webinar. Bye.
bye.